So good evening, friends. In our last presentation, we had discussed some of the important aspects of pediatric and neonatal stroke. We had discussed with the classification, clinical features of a stroke. So a word about neonatal stroke. So most neonatal ischemic strokes are embolic in nature, and the source of embolus is the pulmonary vascular beds or the degenerated placental vessels. So 75% of these single infarct, they occur in the left hemisphere, which are embolic in origin, and the manifestations are very subtle, so they are bound to be missed. So definitive manifestations are irritability, feeding abnormalities, focal motor seizures, usually right-sided, and lethargic. So the area of infarct in neonate is usually the watershed zone between the middle cerebral artery and the anterior cerebral artery, or in between the middle cerebral artery and posterior cerebral artery. The second watershed zone is the tegmentum region of the brain stem that extends longitudinally from the superior colliculus to the medulla oblongata, which is very close to the fourth ventricle. Actually, prematurity and early life infarct, they result in hemorrhagic transformation, while adult watershed infarct, they usually lead to cumulative necrosis. So this we should be aware of. The hemorrhagic transformation may happen in early infarcts. So we now rush to the diagnosis. History is very important. Mode of delivery, developmental history, family history, past medical history, and it also includes examination, dysmorphic features, blood pressure, cyanosis, heart defects, murmurs, bruin neck, ovary skull, or some neuroperitoneal stigmata of neurofibromatosis, Faces syndrome, Fabry's disease. Now, how to proceed with the investigations? Of course, MRI with MR angiogram is the first line of investigation that should be ordered. If that is not possible, then of course we should go for CT scan as the first diagnostic investigation to be ordered. Although CT imaging can demonstrate mature anterior acute ischemic stroke and it can exclude hemorrhage, MRI is really needed to identify early and small infarcts. Diffusion weighted MRI demonstrates infarcts within minutes of onset. So one thing should be noted, if at all during the first 24 hours we are getting a MRI done, so we should always ask for the diffusion weighted imagings, because within minutes it can pick up the changes. Within 2 hours it can pick up the changes that are occurring in the form of infarcts. So MR angiogram can confirm the vascular occlusion and they suggest the possibility of arteriopathy. So here are some of the images of diffusion weighted MRI images which are showing early infarcts. So apart from this, we have to look for the coagulation abnormalities. We have to get a coagulation profile done. ECG has to be ordered, 2D echo depending upon we are suspecting cardiac as the origin of infarcts, and we have to look for iron studies, B12 levels and the homocysteine levels. So one thing should be noted, the thrombophilia profile with protein C, proteinase, antithrombin 3, factor 5 leading mutations, factor 8 levels, lupus, anticoagulants, etc. They should be ordered depending upon the etiology which we are suspecting. Now comes the most important part of the management of stroke. We have to maintain adequate perfusion, oxygenation, normal glycemia, ABC have to be maintained. Hypertension should not be aggressively lowered. So this is one thing which we need to be wary of. Cerebral perfusion has to be maintained at any cost. So we do not have to be very liberal. We have to be a bit more liberal in the management of hypertension. It hasn't to be aggressively lowered down, because we have to take measures to reduce cerebral edema, to decrease raised ICT. Just one thing that is very different regarding the management of stroke in children is that there are a lot of stroke mimics that happen along with stroke in children. So we cannot be very sure of in the very first go we are dealing with a stroke. So we do not have much of guidance regarding thrombolysis therapy, mechanical thrombectomy, that also stays on the same page like thrombolytic therapy. So antiplatelet drugs, they can be used like aspirin, that is used for the secondary prevention of stroke, and sometimes that has to be combined with clopidogrel. Now, depending upon the etiology, there are certain strokes which are very notorious for recurrence, just like arteriopathies, like cardiogenic stroke, like dissections. So there we have to use anticoagulant drugs. Initially, we have to go for lower molecular weight heparin and then a heparin warfarin bridge, and that is followed by oral anticoagulant like heparin or rivaroxaban. So they can be used depending upon the situation. So there are two indications for using anticoagulant drug. One is recurrent cardioembolic stroke and stroke due to dissection. So lower molecular weight heparin is the thing to begin with, and later on it has to be followed by warfarin. One thing should be noted here, that this anticoagulant therapy should not be used in moya-moya disease. In moya-moya disease, there looms a danger for conversion of infarct into hemorrhage. So therefore, we have to refrain from using oral anticoagulants. Now, surgical management sometimes have to be resorted to, like decompressive craniotomy to get rid of the raised ICT, which we are not able to control with the medical measures. So now an important question arises regarding the long-term management, because survivors, they endure long-term neurological impairment in moderate to severe degrees, and a notable concern is with the development of new seizures or epilepsy. So we have to simultaneously put the patient with hemiparesis or any other neurological deficit on rehabilitation programs, and simultaneously we have to initiate management for spasticity and dystonia like baclofen, trihexyphenidyl. And epilepsy is very common in 20% of the children with stroke, so that has to be managed along with. And the incidence of stroke recurrence is 7 to 35%, and so secondary prevention of stroke is the most important aspect. And we have already talked about the primary prevention. In the same manner, the secondary prevention has to be done with warfarin in cardiogenic stroke and arterial dissections, and in rest of the cases we can go for antiplatelet therapy with aspirin. Initially we have to use aspirin in 5 mg per kg per day for 14 days, and later on we can reduce the doses to 1 to 3 mg per kg per day. If we are dealing with a situation like sickle cell disease with a stroke, we have to advise the child for regular blood transfusions, and accordingly we have to manage the primary condition. And in moya-moya syndrome, of course, surgical options, they have to be resorted to. We have to maintain and preserve the perfusion of the brain. So different maneuvers, different surgical options can be taken for in case of moya-moya disease. Just a few slides about perinatal arterial ischemic stroke. So perinatal stroke is very common. It differs from childhood stroke regarding two clinical presentations. One is acute symptomatic neonatal AIS presents with focal seizures at about 24 to 48 hours of life. So day 2, day 3, the patient, the neonate presents with focal seizures. MRI diffusion abnormalities, they confirm the arterial territory affection and the recent infarction, and most of the infants are asymptomatic at birth, and they present in later infancy with signs of early hand preference and congenital hemiparesis. So most of the perinatal acute ischemic stroke, they may go unrecognized, and they may come to the forefront only when the child starts using one of the hands as preferential, and that may be a surrogate marker for congenital hemiparesis. So the imaging may reveal focal encephalomalacia in an arterial territory, and that may be a reminiscent of the earlier stroke, earlier infarcts. So this is, the first one is the diffusion weighted imaging, that is showing restriction, and the other image is showing encephalomalacia, which may probably be a result of perinatal ischemic stroke. So the most important aspect for acute ischemic stroke is the seizure control, but antithrombotic therapy are very rarely required, just in case of cardiac embolism. Actually, in these perinatal strokes, they do not tend to recur. So this is the basic difference between other pediatric strokes or adult strokes and this perinatal stroke. They do not tend to recur. So antithrombotic or anticoagulant therapy are not required in these strokes. So most of them are idiopathic cases. Other causes, the most common cause is because of the thrombotic placentopathy, and most children, they are left with a lifelong disability. So it accounts, perinatal stroke, it accounts for most cases of the hemiparetic cerebral palsy. So the number one cause of hemiparetic cerebral palsy is parental stroke, which might have gone unrecognized due to a number of reasons we have already discussed. Now we have discussed various types of acute ischemic stroke. Now we come to the venous sinus thrombosis, and the incidence is 0.67 per 1 lakh children per year. So it is seen as a complication of common childhood illnesses like ear discharge, infections, meningitis, and head injury. They are some of the precipitating factors for venous sinus thrombosis. And the clinical features are acute onset of seizures along with altered sensorium, comatose state. Most of them, the acute ischemic stroke do not present in such a fulminant manner in comparison to the venous sinus thrombosis. So the presentation is going to be much more fulminant, like stroke-like presentation, cranial nerve palsies, altered sensorium, headaches, and raised ICT. And there are a number of risk factors which can be accounted for, like local or systemic infections, iron deficiency anemia, malignancies, diarrhea, dehydration. They are a leading cause of acute sinus thrombosis in children. Nephrotic syndrome. So nephrotic syndrome and dehydration, these are some of the things which we have to keep in mind. So any child of nephrotic syndrome, any child who is suffering from diarrhea and dehydration, if he presents with seizures, then this possibility should always be kept in mind, that the child may be suffering from acute sinus venous thrombosis. Of course, just like for ischemic stroke, the investigation of choices, MRI with MR angiogram. Similarly, MRI brain with venography, that will confirm the diagnosis. If that is not feasible at the moment, then CT scan with contrast that can be resorted to. So these are some of the markers which independently predict venous sinus thrombosis in a CT scan or MRI. That is ischemia in the parietal lobe and the absence of caudate nucleus. So if these two factors are there, so they independently predict the venous sinus thrombosis. And of course, the management of venous sinus thrombosis is anticoagulation, low molecular weight heparin or unfractionated heparin, and that is followed by long-term anticoagulation with warfarin. So just a few words about, sometimes there might be a bit of hemorrhage, some amount of hemorrhage may be present in the ischemic zone. So that is not a contraindication for starting anticoagulant therapy. Anticoagulant therapy should be started irrespective of the presence of small hemorrhage that may be associated with the sinus venous thrombosis. And usual, and just a ballpark figure, we use it for 3 months or so, because we expect the recanalization to occur in this 3 months to 6 month period. We follow it by repeated imaging at around 3 months, and if recanalization has taken place, then we can think of stopping the oral anticoagulation. Now, hemorrhagic stroke. Nearly half of the childhood strokes are hemorrhagic. This is in contrast to the strokes in adult population. In adult, 80% are ischemic, 20% are hemorrhagic. Here we are dealing with a 50-50% criteria. 50% are ischemic, 50% are hemorrhagic. So the big message coming out of this is hemorrhage do constitute an important part of overall stroke proportions in children. It may be intracerebral or the parenchymal hemorrhage, or it may be subarachnoid hemorrhage. So the etiologies are usually vascular malformation. They are arteriovenous malformation. They could be aneurysm. They could be cavernomas. Bleeding diseases like thrombocytopenia, hemophilia, other coagulopathies, they may also be responsible. And brain tumor, and there may be some hemorrhage that is happening in the brain tumor or the space-occupying lesion, and there could be minor causes like trauma and vasculitis that should be thought of as a causative reasons for hemorrhagic stroke. So as far as the hemorrhagic strokes are concerned, they are much more, they have got a much more stormy onset in the form of seizures, focal deficit, raised intracranial pressure, altered sensoria, and comatose state. On the other hand, subarachnoid hemorrhage, they usually they have altered sensorium, sudden onset vomiting, and the thunderclap headache. That is the worst headache that will ever be experienced by anybody. That is the most common thing that precedes the hemorrhage. So subarachnoid hemorrhage will be excruciating headache, and that will be followed by either altered sensorium, seizures, or vomiting, depending upon the case. So of course, CT scan you have to go for. That is the first line of investigation that should be ordered, and it may be supplemented with angiogram. It may be MRI with MR angiogram or MRI with MR vedogram, depending upon the cause we are suspecting. So the treatment, emergency neurosurgical intervention for very large hematomas, very rapidly expanding hemorrhages, and neuroprotective strategies have to be initiated very soon. And if the cause is some coagulopathy, and that too acquired coagulopathy, then that has to be dealt with in the form of vitamin K, fresh frozen plasma. If the reason is some anticoagulant therapy, and if it is at all a vascular malformation, then a definitive repair or removal of that malformation has to be done. So these are some of the differential diagnoses which are very close mimics of stroke. They can be in the form of migraine, they can be in the form of Tort's palsy, adipose palsy, demyelination, hypoglycemia. So they are mimickers of stroke in children. So there are some other stroke mimics like alternating hemiplegia. So usually the history which we get in alternating hemiplegia of childhood is the child will have one-sided hemiplegia during one episode, and there is shifting. There is shifting of hemiplegia from one side to the other side. And the most important thing is, whenever the child goes to sleep, there will be no paralysis. The paralysis is going to abate as soon as the patient goes to sleep. But early morning the patient gets up, again there will be hemiplegia that will be setting in. So there may be so alternating hemiplegia of childhood should always be kept in mind as a strong differential diagnosis of stroke in children. There could be some channelopathies, sometimes it could be acute cerebral ataxias or vestibulopathies, which we have to. And one thing that should not be forgotten is hypertensive encephalopathy, that is known as Press syndrome. There is documented hypertension, there may be visual symptoms, there may be encephalopathy, and you get a CT scan or you get an MRI done, so you get some evidence of abnormalities that is present in the posterior most region of the occipital region. So that's all with the overall clinical manifestation. So we have discussed the whole spectrum of stroke in children. So the very basic difference in between neonatal stroke and the childhood stroke is the neonatal stroke do not tend to recur. So there doesn't arise any need for long-term anticoagulation, long-term antiplatelet therapy in neonates. On the other hand, pediatric stroke, depending upon the different etiologies, the most common etiology is the arteriopathy that is seen in 40% of the cases. That is followed by cardiogenic stroke, that is followed by thrombophilia, and then some unknown causes. So 40, 30, 20 and 10, depending upon this, these are the usual causes of stroke. And the very basic thing apart from the acute management of stroke is prevention of secondary stroke. That has to be done with either with antiplatelet therapy or that has to be done with anticoagulation. So what are the situations in which we use anticoagulation? There are basically two scenarios. One is recurrent strokes due to cardiac origin or due to arteriopathies, most likely dissection. The one contraindication for using anticoagulation is, apart from the hemorrhagic stroke, is Moya syndrome, because there are high chances it may get converted into hemorrhagic stroke, and that can really worsen the situation. Now a bit about the thrombolytic therapy. This is a very contentious issue regarding the use of thrombolytic therapy in children. We usually do not go after thrombolytic therapy in children. The reason is it is used only during a particular window period, that is up to 4 to 4.5 hours is the window period during which it is known that if we start thrombolysis, then we can salvage the brain from